I came down last night for this meeting and was staying at Euston and decided I would walk up here this morning. And as I was walking here and walking along from Camden, I found myself having repeated moments of deja vu and flashbacks, and remembering very vividly a photo that I need to go and find of myself and my son, Gabriel, who I think is probably about 6 months old at that point. It's clearly cold and wintry. We're standing in a car park and I've got a big black coat on. He's got some ridiculous red pixie hat that we brought him because he was our first child, and you do that kind of thing. And I remember that photo was taken in a car park just between here and Regent's Park, because we were down here for a launch in this very room in the days when this was the King's Fund, and it was the launch of a publication called Meeting the Challenge, which myself and David Allen and Sue State had been the editors and authors of. It was part of the King's Fund Challenge series, which had started with Facing the Challenge. Meeting the Challenge was a description of a number of projects that were being established around the UK, which were about supporting people who presented behavioural challenges in their local communities in all kinds of different ways. We had a project that was set up in Sheffield with 2 small houses in a community to support some guys who'd previously been in St Andrew's Hospital, and that was in there, and various other teams and projects. And Facing the Challenge, of course, had come hard on the heels of significant changes in the late 70s, early 80s in policy and provision for services for people with mental handicap, as it was said in those days, and a number of scandals, including things like Ely Hospital, and TV documentaries like The Silent Minority, which I think was early 80s, 82, something like that. If anybody has not seen that, documentary looking at the horrors of institutional care for people with learning disabilities in places like St Lawrence's Hospital in the south of London, and the appalling abuse and neglect that occurred in those large institutions, and particularly people who presented very challenging behaviour. Gabriel is now 20. Gabriel is at university, and we're here again 20 years later, talking about responses hard on the heels of scandals in places like Winterbourne View, hard on the heels of TV documentary exposing those scandals. And Gabriel is 20, he's away from home, and I worry about things like whether he's getting drunk. I worry about whether he's doing his assignments on time. I worry about friends, choice of girlfriends, etc. I also know a number of parents and work with a number of parents locally and nationally whose children are also away from home, but not through choice, not very rarely as a positive move for personal development or a career, but because there was no other option, because families themselves or others couldn't cope with the challenges that were presented, and someone in their wisdom decided that the best solution was a long way from home, in an institution that is not a university, but maybe a hospital or other kind of institutional provision. And those parents worry about things like, are they safe? And increasingly, since the programme, are they getting the right treatment? Are they being neglected or abused? And when, if ever, are they going to come home? We are clearly useless at learning lessons. And today, although it's entitled Learning the Lessons from Winterbourne View, I hope it'll actually go beyond learning lessons. I hope it's actually about learning the lessons and actually doing something about it. So I hope that is the tone for the conference today, and I hope that that's what you will focus on. Now, unfortunately, you don't get any respite from me because I'm meant to be doing the first presentation. If I can operate this. So, what do we know about supporting people who challenge services is the title. Now, I don't know about you, but whenever people start talking about what do we know, I've been conditioned by media to immediately go into kind of Rumsfeld mode. And if anybody hasn't seen this, you've probably been hibernating for the last few years. But of course, Donald Rumsfeld seems to be known mostly, rather than for his career as Secretary of Defense, but known for his rather odd approach to poetry or other kind of writings or musings, philosophy. And a number of people have this on their walls, but I don't think I've come across an occasion where it's probably more pertinent to think about the fact that there are known knowns. There are things we know. There are known unknowns. That's to say there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know. I could spend a whole morning talking about what do we know about supporting people who challenge services. So, but be reassured, I'm not going to spend the whole morning. So I'm just pulling out some headlines, really, to set the scene. And to talk about people, to talk about labelling, about our understanding, about issues of needing to think about the two sides to understanding behavioural challenges, what our challenges are, and something about rights. What do I know about supporting people who present behavioural challenges? Most of all, I know that they are people. People who have lives, people who have interests, people who have families, people like you and I, people like Mary, who I support. It's not her real name. I know very well that Mary loves chocolate, and when I go to visit her, if I haven't called at the sweet shop on the way to pick up a bar of chocolate, then she's not best pleased with me. But if I do pick up a bar of chocolate, the smile and the grin and the laughter that I get from her when I hand it over is worth a week of slaving away at my desk. She has a wicked sense of humour and is very, very good at taking the piss out of me on a regular basis, which is also very good for my well-being. She's hugely proud to be living in her own home, in her own bungalow, in a seaside town in North Wales after 40 years of living in hospitals, of having been put into a large hospital when she was 14. She is overjoyed to be able to be visited by her family at birthdays and Christmas in ways that she didn't do before. She has them round for dinner. They have her round for dinner. She would, in all likelihood, be irretrievably traumatised by readmission to hospital, and there are good reasons for thinking about that, because she has a chronic bipolar disorder, which means her mood continues to vary from being deeply unhappy and crying and wailing and hurting herself and smearing, to other times of being overexcitable and throwing stuff about and hitting people and so on. But for the last 7 years, we have managed to help people to cope with that and stick with it, knowing full well that to take her back into hospital would just re-traumatise her and actually be of very little benefit. I know about David, who's lived with his parents all his life, stalwart of the local community, very much involved with charitable ventures, working in charity shops, very much liked by the community, huge interest in steam trains and going off on family trips to do those things, who has, in his mid-40s, a sudden and very uncharacteristic change in behaviour that is not normal. Throwing oil-filled radiators down the stairs at his parents was not normal behaviour, but it was certainly pretty challenging. Challenging to the extent that the police decided the most sensitive way of handling this was to send the riot squad round to try and alleviate the situation, which clearly it didn't. He was admitted to hospital, and after a lot of investigations and a lot of diagnostic overshadowing of people on psychiatric wards saying, well, it's behaviour, isn't it? He's got learning disabilities, so it's behaviour. persistence on behalf of my junior staff, who weren't going to take that for an answer, thank heavens, discovered that this man was becoming increasingly ill, and eventually found that he had high calcium levels, a parathyroid tumour, which when removed, lo and behold, 4 days later, the old David that was around reappeared. It's fixed, but because of all that kerfuffle, it actually decided that maybe this was a time to be able to move out from living with elderly parents and to move on to independence. So although that came on the background of traumatic and unhelpful incidents, there is something positive that came out of that in terms of his continued independence. Okay. What's the other thing I know? The other thing that people know about me, and I'm obviously getting old because I'm starting to trot out little catchphrases, but I, in a homage to Herb Lovett, who was a great inspiration to me, who used to talk about people accused of autism, I also talk about people who are accused of challenging behaviour. Because, of course, as you know, challenging behaviour, the original definition, was meant to take the focus away from trying to get the person to stop doing it, to actually think about what the challenge was to other people, to how to understand that person differently, how to support them differently, to find ways of actually coping with the behavioural challenges that they presented. But unfortunately, the term very quickly became corrupted, and we talk about people with challenging behaviour as if it is something that resides within the individual. The challenge resides within them. And people talk about how many people will have challenging behaviour. What's the percentage of people with challenging behaviour in a certain area? And of course, that really isn't the way in which the term was supposed to be used. However, in the challenge of needing to understand people better, we have to acknowledge that maybe 10 to 15% of people with learning disabilities will be seen to be presenting behavioural challenges. Although, I mean, you could read several different papers about what exactly the percentage is, but it's a rough idea. We know that people who have severe self-injurious behaviour are more likely to have more than one behaviour that is seen as challenging. We sort of know, though some people would say actually we don't really know, that it's more likely to be happen in men than women, particularly things like aggression and destruction of property. It's more likely to be in institutional settings, and those people who have more severe, sorry, what I should say is that people with greater degrees of intellectual disability are more likely to demonstrate behavioural challenges. We also know that behaviour problems that are challenging tend to peak between the ages of 15 and 34 and then perhaps decline over time. These are general trends. We know that there are association of certain behaviours with specific syndromes and behaviours that people are likely to find challenging. Lesch-Nyhan syndrome and biting of lips and hands. Cornelia de Lange syndrome and the association with reflux esophagitis and people's behavioural responses to pain. Prader-Willi, people will be aware of the association of rather sort of explosive tempers and behavioural problems, and also a need to seek out food and eat repeatedly, and with autism spectrum disorder. We know that there's an association with mental health problems, and that people with learning disabilities are more likely to have mental health problems. And we also know that there's association with physical illness, as David's case illustrates. But parathyroid tumours are rare. Toothache, headache, stomachache, colds, coughs, blocked ears are not rare, and they can also result in behavioural problems that people may find challenging. Fourth point. Challenging behaviour does not occur in a vacuum. My belief is it is an interpersonal dynamic. For someone to be described as having challenging behaviour, someone else has had to say, I can't stand it. You frighten me. you scare me, you make me angry, you nauseate me, you revolt me, you raise uncomfortable emotions in me which I can't cope with. It may be that the emotion's about I'm very, very worried about you and your safety, but it's still someone else on the other end, and therefore we have to think about the response of the other. We have to think about the variation that I see on a weekly basis in outpatients, where I can see somebody who comes with a carer who will give me chapter and verse about just exactly how dreadful this person has been and how awful the challenges they are and how they need their medication instating or upping or whatever, or different medication. And he can come another week with a different carer who says, oh, well, I don't really find it a problem. It's all right. Occasionally a bit difficult, but one word from me and he laughs and it's all over. How do we account for that variation? Just as an interesting little aside, how do we account for things like Nirbe Singh's research? Nirbe Singh is a psychiatrist, I think, working in the United States, who has a great interest in trying to bring Eastern philosophies and approaches to psychological understandings into Western models. And he's looked at the role of mindfulness training for staff, for parents. I promise this is the only graph I'm going to show you, but I thought I'd make it a good one. Good, isn't it? It's like Christmas decorations. Okay, what's this showing? It's essentially showing a piece of work that was done in 3 group homes for people with young men who presented behavioural challenges and learning disabilities. So each of those longitudinal graphs is one of the group homes. You've got a baseline figures. They did lots and lots of baseline measures. These are just a couple. The black dots are talking about learning objectives, so people's ability to engage in learning objectives and educational, in quote, activities. The top line with the little open dots are about staff interventions, so interventions to try and manage behavioural challenges, okay? So if you look at probably the key message is if you look at the baseline and then you look at the far end, you will see that at the far end of this process, people are more engaged in achieving learning objectives, and there are less in the way of staff interventions in each of those homes, okay? But what they did along the way was they took the staff and gave them their standard behavioural training. These are what behaviours are. This is what causes behaviours. These are response to behaviours, etc. And then went back and measured. They did some alterations of staffing ratios. And then they took the staff and gave them mindfulness training. In summary, there was improvement on all their measures, and that includes things like quality of life of the individual, quality of life of the staff, etc. There's improvement on all those measures after their behavioural training, but there were greater improvements after the mindfulness training. And more importantly, the gains made with mindfulness training were able to be sustained with lower staff-client ratios than with behavioural training. And that matches up with other work that he's done, for example, working with parents of children with autism who present behavioural challenges, doing nothing with the child themselves, merely taking the parents and giving them mindfulness training and demonstrating that the graphs of behaviour problems reduce quite dramatically just through working with parents. How do we explain that? We have to think about the interpersonal dynamic of challenging behaviour. How do we respond to challenges? What is it that we do when somebody challenges us? How do we manage that? So the challenge is to be accepting and at the same time creative and capable. And in a report that was produced between the Royal College of Psychiatrists, British Psychological Society, Royal College of Speech and Language Therapists and various others, and in which Jim Mansell was a member of that working group and hugely influential on that report. It talks about capable environments, and it also talks about what we mean by having creative responses. overturning traditional or long-standing responses to behaviours, adopting counterintuitive ideas, questioning the necessity for established reputation and practice around the individual, taking managed risks, adopting greater flexibility of roles and responsibilities, establishing creative and unconventional working partnerships between individuals, community supports, voluntary and statutory agencies and professionals. This obviously in essence is what the term challenging is about. The challenge is to do things differently. Actually, I lied when I said you're only getting one graph. These were just two diagrams that Jim provided. Quick explanation. If you think of the dotted line as increasing challenges, increasing needs on behalf of individuals with learning disabilities. So as the need increases as it goes up, and you look at the range of service provision for that need, what tends to happen is that the range and skills and quality of service provision is very, very flat until you get to people who are very, very challenging and demanding and start getting into kind of trouble with the police and placement breakdown. And then suddenly there's service provision. Suddenly there are people that say, we specialise in taking people with challenging behaviours. We have special hospitals, independent institutions or other things or services that can intervene at this point. And of course what we really want is to have the two lines paralleling each other, so that services and their abilities and their skills and their flexibility and their creativity increase to parallel the increasing demand of the individuals. And then final point, and there are people more qualified than myself to talk about this later on, but the other concern is about violations of rights. We know that challenging behaviour is a major predictor of abuse. Study in Montreal, I think, looking at staff responses to challenging behaviour and finding that at least a significant proportion of staff said that their response to challenging behaviour from a client was to hit them back. We know that there is inappropriate use of medication. We know that there are high levels of prescribing of antipsychotics which there is no evidence that they manage behaviour. There's evidence that they manage psychosis or they can manage high levels of anxiety, but they don't just treat behaviour. And yet we know that people with learning disabilities who present behavioural challenges are more likely to be on antipsychotics and on high doses of those. We know about the use of restrictive and punitive interventions. This is no news to us. When I, 20 years ago, was knocking around here, the other people who were knocking around here were people like Anne Donnellan and Gary Lavinia and others who were publishing at that time work about non-aversive behavioural interventions. People with learning disabilities who present behavioural challenges are more likely to be socially excluded, to suffer from deprivation and neglect. And it's with those things in mind that the National Strategy Group for Challenging Behaviour, which I'm involved with as part of the steering group, in which Viv Cooper, who will be talking to you next, leads through the Challenging Behaviour Foundation, produced a charter. Now, there are always charters around, and people will remember the NHS charter, again, probably from 20 years ago or something like that. And in Jim Mansell's original report, there was a suggestion for a charter. I think the important point about charters is not that we sit and read them. Charters should be things that people themselves hold in their hands and say, okay, if you have said that I am behaviourally challenging, then what are you going to do about it? And I have here a piece of paper that says you ought to be doing the following. You ought to be recognising that people have the same human rights as everyone else, to be healthy, full and valued members of their community. that people will find everything they can about a child who has behaviour problems at an as early stage as possible and help and support their family. Families will be helped to be healthy and happy together. People will have their own person-centred plans and support, including good support with communication. And that support will change if it needs to, and it will be local. It will not be 170 miles away. People will have the best help to be as well and as healthy as they can be. And they have the same rights as everyone else to a family, social life, relationships, housing, education, work and leisure. As we're going through this, bring to mind people who you know who present severe behavioural challenges and ask yourself how their care and their situation is matching up to these principles in the Charter. Care and support is given by people who are properly trained. They should support the person with whatever they need and whatever problems they have, and they should be provided in ways that have been shown to work best. And from time to time they may need extra help from specialists. People should receive positive behavioural support, and also people should make sure that people are not hurt or made to feel bad by the things that are done to cope with difficult behaviour. And everyone must make sure they find out what are the best ways to help people who have problems. They must find out what's up to date and what works from people who study these things. Web link at the top is for the Challenging Behaviour Foundation's website, where you can download that charter, and there's the easy read version which we just had, and then there's also a more extended version. And if you're interested in looking at the report that I mentioned, a unified approach to the Royal College, then that is a web link that you can